So Lisa is pulling double duty tonight, so she's gonna do the best she can, but hopefully Matt and I will do this topic justice. Just like I said, it's what we've got prepared is fairly high level, and it should be applicable to any kind of health insurance. But please, if you have specific questions, either speak up and interrupt us, that's okay, or we've got time for questions at the end, and we'll definitely do our best to answer any specific questions you have as well. So what we were planning to talk through today is we want to talk a little bit about the patient services that we actually offer here at UChicago. I will say too, I think all of us can attest that we offer similar services that other hospitals are going to offer as well. So if you're ever not in the UChicago network, hopefully what we're describing here today is something, if you're in Florida, that hospitals in the warmer states will have as well. And maybe we'll give you some ideas about who to ask for if you need to get some help with something. We're going to talk a little bit about network status as it relates to insurance, and then some of the referral authorization and denials nomenclature that can be frustrating and confusing at times as well. And then we'll wrap up with some stuff about financial assistance discounts and No Surprises Act and what that means for patients when it comes to getting bills. And then we'll leave plenty of time for questions. So please, if I talk about anything or Matt or Lisa, if we say anything that sounds a little bit confusing, please interrupt us right away. We'll be happy to explain more while we're talking through this. So one of the things that I really wish more patients knew about, I think we try and share this with everybody, and every hospital I've worked at tries to share this, but I still think it's one of those things that's like sort of a secret. It's not a secret. We're not trying to keep it a secret, but I think people don't really often know that we have pretty robust financial counseling services. And there are some things that we, will start with for a patient just kind of as a standard to start the conversation. But the financial counseling team is there to work with individuals and review their specific situation and needs. So this is not the kind of service where the same patient gets, or every patient gets the same thing. This is very personalized because every patient and family is going to need something different. So the financial counseling team can do things like give estimates. If there is a question about what a service is going to cost, they can project and actually even estimate that against insurance benefits and tell a patient, how much do we think this is actually going to cost you? Not what are the charges, but how much do you have maybe in your deductible or your copay? And at the end of the line, what's the bill going to look like for you? We also offer financial assistance. And at UChicago, our financial assistance program goes all the way up to 600% of federal poverty line, which actually is higher than required and higher than some other hospitals go. So we do our best to really make sure that we're helping patients and families who may not have the ability to pay out of pocket for all of their services. But in addition to that, we also help with finding insurance eligibility. A great example is if a patient maybe just lost their work insurance, we can help them figure out, do they qualify for Affordable Care Act plans, or can we maybe even help them get them set up with their COBRA insurance from their employer or their last group health plan. And then we also help with things like payment plans and explaining what insurances are available that we are contracted with as well. So that's a little bit about what we offer with our internal financial counselors. Matt and Lisa, is there anything that I missed on that you want to add some color to?
No, I think you've covered it all, Nicole. I will say that while we do a lot of these services with our patients, I think the one thing that stands out most, at least to Matt and I, and some of the stuff that comes across our desk and our email, is the explanation of network insurances. I think that's really complicated for folks on where they can understand that they can go for their services and if they're in and out of network, and really what does that mean for them at the end of the day when they need these services. And I know you're going to get into that a little bit more, but I think that's the one that stands out to me the most for our services.
Yeah,
Excuse me.
thanks, Lisa. Um, we also have a company. Sorry, Matt, I saw you just came off mute. Did you have something
Oh,
to add too?
no, no,
No?
sorry.
Okay. We also have a company that we partner with. They're called Elevate Patient Financial Solutions, and they are experts in Medicaid eligibility and enrollment. And they also have expertise in SSDI and SSI programs, so they can help patients who qualify for Social Security, disability, and income and supplemental security income benefits. They can help with that enrollment process. They go so far if there's a hearing or appeals that need to be filed, they will go to the hearing and represent our patients. They will file appeals. They will do a field visit to a patient's house if that's required in order to gather information for the applications. They'll help obtain birth certificates and all of the paperwork that's required to apply for these programs. They are there to help through the entire process from start to finish. We offer this at no cost to our patients. And they're available all the time for anybody who needs it. So this again, we're not unique in this. There are a lot, most hospitals probably have someone that they either partner with full time or can connect patients to, but I don't know that this is something that is well understood by everybody. So we wanted to make sure that we called this out as well. Matt, anything to add on that?
No, maybe one additional thing is a lot of times there is confusion around the Medicaid piece, and Elevate does a great job to help get that set up. But again, that's where the financial counselors can also really speak to your specific situation, right? Each person's situation is different. Our financial counselors are really good at recognizing that and helping kind of navigate that beyond just the submission of those applications as well.
Great. Thank you, Matt. Okay, so moving on, and I apologize, there's a lot of, it's kind of boring terminology, but hopefully little tidbits of information here are going to be helpful. One of the things that we find, as Lisa mentioned, we have to really help patients and families understand is navigating networks. What's in network? What's out of network? Am I okay to go to this doctor? Am I okay to go to that physical therapist? What about, this pharmacy? Can I get my med from this pharmacy or do I have to get it from a special mail order pharmacy? It can be really challenging to navigate those things. And so we just wanted to kind of start out with the basics that when something is considered in network, it is because your plan has a direct contract with that provider, whether it's a pharmacy, a doctor, a hospital. And that generally means that services are covered at a lower cost to the patient. There are going to be lower copays, deductibles, and coinsurance. And sometimes, depending on the plan, there is no copay or coinsurance if you're using an in-network provider. But when you go to see an out-of-network provider, the providers are not contracted with that plan. And so what that ends up meaning at the end is that usually that means it's going to cost more. Usually it means higher copays, higher deductibles, higher coinsurance. Some plans won't cover out-of-network care at all unless it's an emergency. Generally, those are going to be HMO plans. So if you're choosing a plan, know that, and I'll talk a little bit about HMO versus PPO in a second here, but HMO plans are going to be the ones that are most likely to not have out-of-network benefits. And so then what that means for things like an out-of-pocket maximum. So after the Affordable Care Act went in, every plan that meets the Affordable Care Act guidelines is required to have limits on out-of-pocket maximums for patients. And those can be two different numbers for in-network and out-of-network, but when you hit that maximum for the year, your plan then covers everything else the rest of the calendar year. And that calendar year might be different depending on what your insurance is. So that's another thing to know is when does your year start? It's not always January 1. So you want to pay attention to that as well. And then I've mentioned briefly the difference between a PPO and an HMO. A PPO is usually going to give a patient more flexibility to select providers. You're going to have options to go out of network or have a broader network, but usually when you choose an out of network provider, you have a little bit higher of a cost. So sometimes that means a higher copay for a specialist visit, or a higher coinsurance. Maybe you have a 30% coinsurance instead of a 20% coinsurance, but that's how a PPO plan controls network utilization, whereas an HMO tends to be more specific. So the number one takeaway is knowing your network status before you go to a doctor or a caregiver or get a prescription filled is really important to help avoid unexpected medical bills. And it should be a question that any healthcare provider can answer for you, or your insurance card you can call the number on the back of your insurance card and tell them who you want to see, and they will tell you if they're in network or not. Really important when it comes to high medical costs. I've seen people choose to go to out-of-network providers thinking that it wouldn't be that much more, but something that's really important to keep in mind is that out-of-network providers don't have a contract with your insurance company, which means that they do not have to accept any discounts either. They can choose to if they want to, but they don't have to. So I've seen people who thought they were only going to have to pay for their out-of-network deductible, when in reality they had a bill that was much, much, much higher because they also had to pay for all of the discounts that the insurance company wanted to take. So that is something that I really emphasize very strongly is pay attention to network status, because it will really make a difference. That being said, I'm going to talk about authorizations here in a second. If you need to see a specialist who is a very niche specialist, who is handles a very unique disease type or a unique treatment type, most networks will allow for exceptions when clinical rationale justifies the case. It's not easy. I'm not going to lie about that. Matt and Lisa spend a lot of their hours every day trying to help justify approvals to insurance companies so that we can take care of patients, but it can be done. The important thing is to try that first so that you don't get surprised. So I'm going to flip to the next slide where we've got a little bit of information about what is a referral, what is an authorization, what is a predetermination. They're all going to be, I would say, a type of approval to see a healthcare provider. But they are slightly different in how they work and when they work. And then the one thing I didn't put on here, I'll mention two things I didn't put on here. If you're totally out of network, you might need one of these and either a gap exception or a single case agreement. And a network gap exception is the description for when you make a case to your insurance company to say, I need to go to this particular provider that is out of network, but here's the reason I need to go to them, whether that's their clinical specialization or the treatment, or sometimes it's location. Sometimes maybe they're the closest doctor that can help you with what you need. You can request that network gap exception. And that is when the insurance company takes a look at your justification and says, okay, maybe I agree with you, or maybe I don't. If I agree with you, I'm going to give you permission to go see this doctor, and we're going to treat that like they're in network. So it is possible, especially when you have really unique care needs, to get those approvals, but it takes a lot of work, and you're going to want to lean on your healthcare provider and take all the support they'll give you. You're going to need clinical justification. You're going to need to be able to answer questions to your insurance company about why it's important for you to go to that person or that facility. Setting that aside for just a second and just assuming that you're in network, the three different types of approvals we call out here are a referral, which is most often going to be needed with an HMO plan. The way HMO plans work is they entrust a primary care physician or a PCP to manage your care, right? So basically everything you do sort of needs that referral from that primary care provider who's centralized in managing all of your I'd say your care continuum or your specialist continuum. They don't need to deliver your specialty care, obviously, but they need to say, yes, this patient that I'm managing needs to go see this specialist for this reason. So when you have an HMO plan, in order to visit a specialist, you almost always need a referral, and that will come from your primary care provider. In addition to referrals, there are authorizations. Sometimes you might hear this as a pre-certification as well. And these are specific approvals for services, procedures, or medications. It tends to be for things like surgery, advanced imaging, and high dollar medications tend to all require authorizations. And what happens with those is the provider, usually the doctor, the pharmacy, or the hospital, is going to submit the plan of care or the codes for the treatment along with the diagnosis information, and they're going to request approval from the insurance company. Sometimes that comes really quickly. Sometimes we get that back almost immediately, right, Matt? And other times it can take weeks. So this one can be one of those that's really easy, or it can be a little bit scary, especially when it doesn't go through right away. And I'll get to in a minute what happens when they get denied. And then this third one is not as common as the other two. It's predetermination. The predetermination is sort of like an early request to the insurance company to say, please take a look at this specific care that is planned and let us know if you will pay and how much you will pay. And so it's a little bit more specific than an authorization in that it also looks at, is the insurance company going to pay for it? So this one is really helpful if maybe you have a high deductible or you're thinking about something that maybe won't be covered or is cosmetic in nature or is sometimes experimental in nature. These predeterminations can really help make sure that you don't get any unwanted surprises. I'm going to pause there for a second. I feel like I'm talking too much. Matt and Lisa, anything you want to add to this so far?
No, you're doing great.
Yeah.
You're covering it all.
All right. I promise we don't have that many more. I have like 2 more slides, not much. Okay, so sometimes though, you get a no, right? And that's where we come in. Matt and Lisa and our teams spend a lot of their time dealing with the no's and trying to help combat those for people. But they can come at different stages in a patient's care. So a prior authorization denial, and I will share with all of you, I specifically spend a lot of time talking about this with my colleagues, even in healthcare as well, because the word denial gets used a lot. And it can mean different things in different settings. And one thing that I really want patients to know is that just because you heard the word denial doesn't mean that there aren't options, and it doesn't mean that you'll have to pay. It could mean those things, but it doesn't automatically mean those things. So what I would say and tell everybody who might need to hear this is don't panic, ask for help. Like, we're here for a reason, and we do this every day. We can help navigate these processes for patients. And unfortunately, sometimes insurance companies will send a letter directly to a patient's house saying we denied, your request for authorization for this service. Half the time we're already appealing it, and maybe we've even got it overturned, but the patient gets that letter and they panic thinking they're not going to be able to get the care they need. So that would be my personal message to everybody is, just because you get that letter from your insurance company doesn't mean that's the final say. And just make sure, get in touch with your healthcare provider or your care team and say, who can help me figure this out? There's going to be someone who will help you work through it. So the prior authorization denial occurs before a medical service, procedure, or medication. Usually we're asking for that authorization beforehand. And when we get a denial there, usually that means we need to submit additional documentation or an appeal to justify the service. Sometimes services are just not going to be covered, and you may need to agree to payment if you choose to proceed with those. And I'll give a fairly common example of that we see. Although insurance companies are getting better at it, many insurances don't cover genetic testing very well. Or they might cover it once a lifetime, and that's it. And you might need, another version or something. So that might be an example of a non-covered service where they just have a policy that they won't cover it. And you might want to say, okay, but I'm going to get that lab work done anyway, because I really want that genetic sequencing. We need it to decide the care plan. So let's figure out what that's going to cost. And that conversation can happen after, if the appeals and additional documentation doesn't suffice to get that overturned. But that's in advance, and you can plan ahead for that. Another type of denial that we see is a concurrent review denial. And this is like during the process. So this might be if a patient is an inpatient in the hospital, and what we do is every time a patient gets admitted, we get authorization from the insurance company, and sometimes they'll say, okay, we're gonna give you approval for 5 days. And then before day 5, we have to call the insurance company again and let them know what the status is with the patient and ask for more days. And they'll say yes, or they might say no. If they say yes, they tell us how many more days we get, and then if the patient hasn't gone home by the end of that time, we'll call and ask for more days. Sometimes they say, no, we're not going to approve more days. That's when it's called a concurrent review denial. So we usually do one of two things. We appeal, and we provide additional documentation. We might have our physician do what's called a peer-to-peer, and a physician at the hospital will talk to a physician at the insurance company and explain the situation and ask them to overturn and approve the rest of the stay. Usually that's successful. We're more often successful than not with those conversations. And actually, we know this because we've recently started tracking it more closely. Our internal physicians win 80% of the time. The insurance company agrees with our internal physician. So when I say we usually win, we usually win. In some rare instances, the additional days may not be justified. And what should happen in those instances, if that were ever to occur, is somebody would come talk to you and explain what was going on and say, we either need a discharge plan, or if you really want to stay in the hospital, here are our financial options, and give an opportunity to go through those and make a decision with a financial counselor and a social worker and a case manager helping to guide the decision. Those are rare. We don't often see these, like I said, and when we do see them, we are usually able to appeal them successfully. And then the third one is when we actually submit the bill to the insurance and then they deny it. This occurs after the service has already been provided. We appeal these. many times if we have to. We win almost all of these as well. Sometimes, in rare instances, a billing denial might end up in a larger bill, but often if it's gotten all the way to that kind of stage of the game, the billing provider has already kind of anticipated that, and they may end up writing that off internally as opposed to passing the bill along. So again, I would say the important thing here is if you see one of these, if they come to you, just know that you don't have to navigate it alone. You can reach out to the customer service team at the hospital, reach out to a financial counselor, reach out to your care team if that's who you know, and somebody will be able to get you connected with someone who can help navigate it. Okay. And then last two, and I talked way too much. I'm so sorry. I'm going to do these really quickly. So, like I said, we offer financial assistance for anyone who has income below 600% of the federal poverty line, or their financial responsibility exceeds 20% of their annual income. For adult households, that includes spouses and dependents, but it doesn't, this is another thing I like to make sure people know. Once you are 18, you do not have to take, you are an adult and responsible for your own medical bills. So I think that's really important for teenagers to know, because even if you're 19 and living at home, mom and dad's income doesn't factor into whether you get approved for financial assistance. So adults who are living with other adults don't have to count those other adults in their income, in their household income, if I explain that clearly. Which benefits people more than not, because a lot of times when somebody's living, especially like a young adult is living at home, their parents are thinking, oh, like especially if you think about college, right? Your parents' income still matters even though you're an adult. It doesn't work that way here. You don't have to claim, that as part of your household income. So that helps particularly young people and adults who are living with other adults who maybe have more of a solid income. We do approve financial assistance in 12-month increments too. So when you get approved, it's good for a year. You don't have to come back for another 12 months, and it's a really quick and easy process. And then we also offer payment plans. And again, we can, tailor those to the needs of the specific situation. And then we also offer prompt pay discounts if that's something that would be helpful to people. So that's something I encourage people to know this, because you can ask for these kinds of support or discounts from any healthcare provider, and they will probably have some type of program similar to this that would help. And then our last slide is about the No Surprises Act, which went into effect in January of 2022. And this one really provides some key protection for patients. Illinois patients had the benefit of some of these protections under state law since 2011. But there was no federal law on this. So since 2022, there's now federal protection for patients. It applies to every state. You cannot get a surprise bill for emergency care from an out-of-network physician or hospital. If you have an emergency, you can go to any healthcare provider that participates in the Medicare program, and you can get treatment at your in-network rates, regardless of your network status. So that's really important for people to know. And that also means even if you get an X-ray or have anesthesia, the doctors that are reading your exams or processing, the pathologist that's processing the lab, if they are out of network, they cannot surprise bill you either, as long as you went to an in-network service, an in-network hospital or an in-network facility to get the appointment. It also has some protections for uninsured and self-pay patients with good faith estimates. And there is an independent dispute resolution process, which I call that out because what that means is healthcare providers can't send the bill to the patient and say, well, you figure it out with your insurance. This means that they have to go directly, the healthcare provider and the insurance plan have to work it out between themselves without putting the patient in the middle of it. So there is, every hospital should have information about this and who you can call if you feel like you're not getting the service you should be getting. in relation to the No Surprises Act. But that's been a really great change federally that protects patients regardless of what state you're in. Okay, I am going to stop there. We have our contact information in here, so I'm sure we can get this out to everybody. We can take questions today, but we can also field questions later if you ever need to email us or anything as well.